Hello, and welcome to the Center for Health Technology and Innovations webinar series from the American Heart Association. We are here today to discuss AI agents from chatbots to patient prescribing. And we have brought together a panelist of experts in this area, so we're looking forward to a really interesting and energizing conversation about AI agents. Just as a way of brief introduction, for our panelists, we're joined by Frank Conti Ravston from Meggie Health. Meggie Health starts with pregnancy care and continues with lifelong heart support, predicting preeclampsia, monitoring postpartum, and extending to lifelong care. We're also joined by Eric Rock from Percipio Health. Percipio Health provides a population health monitoring platform via smartphone, multi-signal analysis, and clinical intelligence for predictive insights and next best actions. And finally, we're joined by Severance McLaughlin from DeLorean Artificial Intelligence. DeLorean AI provides Marty the medical artificial real-time intelligence, and Marty helps payers and at-risk providers by identifying patients at risk of costly health events, enabling proactive intervention for prevention and mitigation. So thank you to our panel for joining us. I'm Joseph Villa. I'm founder of Bigby Labs. Bigby is a technology incubator currently focused on supporting the 53 million informal caregivers, caring for friends, families, and neighbors. I'm a longtime collaborator with the American Heart Association and have been building multi-agent systems for, I hate to say this, nearly 30 years. So I've been at this for, as the cool kids say these days, for a minute. Uh, so I'm going to start with some definitions and some positioning. I've been in a lot of these conversations, and too often we jump into the discussion about AI without really defining what we're discussing. So I'm going to spend a little time on that, and then we'll get into the discussion. So we're here to talk about AI agents, or what are sometimes in industry speak called agentic AI. And broadly speaking, we're just going to say agentic AI or AI agents is a software system that acts independently in healthcare processes with minimal clinical oversight. So my position on this, which may be a little bit provocative for the conversation that we're in, is that agentic AI is neither agentic nor is it AI. And as I like to say, sometimes a jelly donut is just a jelly donut, and that's okay. So my view is that knowing what something is or isn't is critical to understanding what it can or cannot do. So things like chatting or prescribing. And my take is that we are in a moment where the marketing hype has overwhelmed the technology reality. And separating hype from reality is especially important in healthcare where patient safety is paramount. And so the good news is that there are serious people, we have three of them here to talk to us today, who are doing serious work that moves us beyond the hype and into the reality of what AI can offer us and what AI agents can offer us. So if I were to say, this is not agentic AI, this is a jelly donut, I think we could all agree on that reasonably quickly. I think we wouldn't really have to spend much time defining what AI is or defining what an agent is. We have an intuitive sense of what a jelly donut is. But if I were to say, the donut wants to be enjoyed, and so it cloaks itself in sugar, I could say that in some sense that represents goal-driven autonomy. Or if I were to say a donut senses its environment and adapts its color in response, being put into hot oil and turning a beautiful golden brown, I could say it's context aware. See, it learns and adapts. Or if I say that the donut initializes in an unfilled state and modifies to filled, I could say it evolves over time. In which case, I could say, this is agentic AI. See, it's a jelly donut, but it's agentic AI because it's goal-driven, context-aware, and evolves. But I think we'd all agree pretty quickly again that it's not agentic AI because we have, again, a good sense of what a jelly donut is. And we don't even really have to worry about the definitions because we understand what the jelly donut is. But if I say this is agentic AI, then suddenly maybe our shared understanding of what this picture means isn't as solid as our shared understanding of a jelly donut. So let's spend half a moment just breaking this down because it's actually simpler than we might think. So there's two parts, the AI part and the agent part. And so let's start with talking about what AI is about. An AI, as it's most commonly understood today, is a statistical function indicated here by this little F0 that takes a prompt, a series of words represented by the X, and returns a response represented by the Y. And we frequently experience these functions as large language models or LLMs like ChatGPT, Claude, Gemini, and others. And I'm sure you've all experienced this. So you might go to ChatGPT and you might say something like, "Where is Paris located?" And ChatGPT calculates the most probable text output given this series of words, "Where is Paris located?" And it gives you the most probable response. And it'll say something about Paris being located in northern and central France, et cetera, which probabilistically speaking is a pretty good answer. Unless you happen to be one of the 25,000 people who live in Paris, Texas, in which case you might find this answer a little bit not fully satisfying. You may also say something like, "What's the best route from Paris to Odessa?" And again, GPT is going to calculate for you the most probabilistically likely text output to that particular input. And it's going to tell you a lot of stuff about taking buses and trains and how to get from here to there. And again, you might find that a little confusing if you're trying to drive across Texas on your way through Dallas. So we've got AI, which is a probabilistic function that takes a series of word inputs, does a probabilistic calculation, and then creates a series of word outputs. And then we have this agent part. So the agent part is essentially we take our AI, X to Y, and we attach a harness to it. And a harness is essentially a piece of software that takes now, instead of a probabilistically identified sentence, a probabilistically identified action, and it does something in the real world. It makes a call to an external system, it sends an instruction out, and then something comes back from the real world. The harness then re-provides that back to the large language model. The large language model will then loop. It will generate a new action. The harness will take the action, and that will continue until some condition is met. So again, you might say something like, "Get me from Odessa to Paris." And on a probabilistic basis, the AI agent now is going to do some things. It's going to book an airline for you. It's going to book some hotels for you. And very helpfully, it may even purchase a bakery for you in case you get hungry on your way from Paris to Odessa. So again, these are not probabilistically speaking, not terrible things, but in the context of our poor farmer here who's just trying to get across state, these don't exactly hit home as the things that she wanted to have happen. So we oftentimes then say, okay, this is agentic AI. We've got AI running, generating these probabilistic outputs. We feed it into a harness, and we then loop it until some situation is resolved. So the question is this AI? Is this agentic? Or is this AI washing? And fortunately, we don't have to ask this question in a vacuum. For the last 70 years, AI research has been thinking about this question of what is AI and what are agents. And there's a set. So first of all, I should say there is no well and fully agreed upon definition of what constitutes AI. However, there are a series of themes that emerge that have become relatively stable over the last 70 years. And I've got them here. I'm not going to talk you through each one. Let's just take this as a thought experiment and say, if we had a doctor who was exhibiting these qualities, but our doctor didn't understand anatomy, didn't understand physiology, or didn't understand anything about how the human body works, can't explain their clinical reasoning, but could make up good stories about why their reasoning sounded right. They couldn't treat you unless they had seen the specific case before. They remembered nothing from any of your prior encounters or didn't learn from their experiences with you or with another patient. I think we could agree that this doesn't seem like a very intelligent practitioner. I hope we could agree with that. And therefore, I think if we say AI also doesn't exhibit these characteristics, that we might question whether it fits the definition of intelligence that has been established over these 70 years of research. And then if we said there are reasonably well agreed upon characteristics of agents, then again, if we take our real human example and said, what if our doctor didn't really care intrinsically about whether or not you got better, needed you to constantly bring them back on track, didn't notice or couldn't tell whether things were changing over time, and couldn't recognize if they were making things worse and didn't change their care plan in response. I think we could agree that that doesn't feel like someone who's acting very autonomously or in our interest or on our behalf. And many of our agents today, our software agents, in fact, look a lot like this. So that's the basis on which I say this is neither AI nor is it agentic. And that's just one man's perspective. So I think the thing that makes this relevant and not just word mincing is that the consequences of the hype, and in particular for us in healthcare, is that we're talking about patient harm. There are other consequences of following the hype if this is not accurate hype. I'm not going to go through them. For us today, the real issue is around patient harm and patient service. So what's the value of calling AI what it actually is? Well, it means that, or using words carefully, it means that things can be in harmony, that we can have balance in the different technologies that we're bringing to bear, and that our farmer can finally be at home eating that jelly donut. So an interesting thing is happening these days. As the LLMs are starting to reach some limits, the deep learnings or LLM community is starting to pull in lessons from the last 70 years. And so we're starting to see hybrids emerge where prior technologies are being coupled with the LLMs. And we're starting to see more robust solutions that actually build on 70 years of work instead of ignoring 70 years of work. And I find this extraordinarily heartening. Um, some of those people are people right here at the AHA. And so Pat Dunn, who's on our call today from the American Heart Association, has published a really interesting paper looking at the role of neurosymbolic AI and neurosymbolic agentic AI in cardiovascular care. And we have a panel of three experts here to help us think about this more fully as well. So I'm going to turn off my screen if I can pull this off. I think my screen is still on. Is my screen still on? I can't actually tell.
Hi, Joseph. We do not see your screen share.
Fantastic. Thank you. Great. So I'm going to turn it to the panel now. And I think my first question for you, just to get us kicked off, is where would you refine, push back on, or extend our understanding of AI agents, and particularly as it relates in healthcare to our audience here, who is predominantly a healthcare and predominantly a clinical audience. So would any of you like to jump in on where we might refine our thinking?
I'm happy to get in there. You have to. Am I on mute? No.
Nope.
Just I think you did a really good job defining agentic AI, especially separating the bot from the AI or the cloak of AI. I do think that for this audience, it's important to understand the fundamentals of the different types of AI. Like you mentioned, the bot, you did a really good job. The large language model, right? One could argue that large language model is just a data science tool, NLP combined with software. And then looking at AI, but there's also foundational models, right? That are learning, have the ability to predict an event in the future and the ability to change that event in the future. Um, and I think, like you said, there's a lot of marketing hype, and that brings back worries about Watson, right? Watson promised a lot of great things to the healthcare industry and failed miserably to the point where I think MD Anderson paid them to leave, which I think is a great business model. Um, But but coming back and saying patient harm and patient safety, I do think we need to actually look on the positive, right? There is patient harm or potential for patient harm, but I think we should look at the benefits. And I'm going to say some things that might be controversial to your viewership right now, right? There's been a number of Harvard studies that have shown that a doctor in diagnosing, a medical professional diagnosing, is about 56% accurate, where some of these machines in their accuracy in diagnosis or predicting are upper 80s and lower 90s. And then, you have to understand like what is better, right? Is it the physician alone? Is it the machine alone, or is it combined? And I use the analogy, do you want to be on that plane from Paris, Texas to Paris, France with just the pilot or just the machine or both? And I'd want both, right? I want a fallback. And I think a lot of the challenges that you're hearing and you bring up, rightfully so, come from the LLM advent, right? Where you had ChatGPT and then Claude. And but that was the first time people were actually able to touch and feel what real AI was. And it reminds me of what the Netscape effect happened back in if you're old enough to understand that, in the early 2000s. So I think, doctors are realizing that, Claude is not going to be able to do the diagnostics for it, like you rightfully so, if they've never seen this before. And I think there's a really big difference in learning, right? AI is really good at learning, but reasoning is completely separate, right? That's a human conscious capability. And knowing the limitations of the AI, where our team works is, in cardio AI or renal AI, is our job of our AI is to provide the physician all the information that they could possibly have to make the best decision possible, allowing them to uh, to operate at the top of their license, if you will, right? A human cannot process that many data points, but giving them all the options makes them a better informed medical decision. So I think there's a lot. So I come back for patient harm. I'd say there's a lot of opportunity for patient care if the machines are properly vetted and validated. And again, you've got three scientists plus yourself on here, and we've done this before, like as you said, over the last 70 years, right? We've done this before. We can implement this. We can improve the healthcare quality. And I'd love to hear Eric and Fran's point of views as well on this.
Yeah, thank you both, Joseph and Severance. Really interesting perspectives, and I think a couple of thoughts to kind of add to that. I think when clinicians are thinking about AI, it's really important that they understand, both the amazing capabilities, but also the limitations. And one of the things that I find very interesting is this sort of human AI interface relationships. How does it actually work on the ground? And something that's come up in different settings, so not just in healthcare, is actually if you're a good manager, you tend to work with AI really well because you're very clear about what the goal is, what you want it to achieve. So it's akin to managing a person. You need to be very specific. You need to give it a good prompt. You also need to give it the capability to critique you because they are inherently sycophantic. They want to please you, and they want you to keep talking to them. And this is very much talking specifically about the large language model, right? So those that conversational capability that has become, so generative AI has sort of become synonymous with AI, but it is very much a subset. So I think we know clinicians are using AI. This is happening, and there's actually the first safety cases have been brought to court because patients are unhappy about how clinicians are using their AI, often completely unregulated. So it's not actually within a trust, within a healthcare system environment. They're just ad hoc using it. When you're ad hoc using something, like I said, all of those limitations and challenges are there. So yes, it can feel like a really great diagnostic add-on, or it can help you to remind yourself about a guideline, but it is still, in my view, way too risky. So I think clinicians need to understand actually how this works, and I think that probably understanding that it is a prediction, that there is no inherent understanding of medicine, that it wants to please you, that it can make mistakes and sound really convincing. I call it, sorry for all the white men here, but I call it like white male syndrome, like it says things really convincingly, even though it doesn't have the expertise. So I think that's one aspect that's really important from a kind of AI in healthcare. Be very careful. And if you're thinking about using a tool, I think most healthcare systems may have processes in place or can give you some education to help support you in which tools you should be using. The second question is, who is the user? So we said, if you're a manager, if you're good at managing people, you may be really good at managing your AI. But it vastly depends on experience, right? So we've seen tools, for example, in radiology. And if you're a very junior resident or doctor, it actually really improves your diagnostic performance. Whereas if you're a really senior radiologist who's been working for many, many years, that deep learning AI algorithm, actually, they stop using it because it's not useful. And I think we have to remember that medicine is very, very human. As Severance has said, people make mistakes. We're all human, and the system, because it's such healthcare itself is so complex. And so when I think about AI now in healthcare, I think less about the model and how good the model is, and thinking really about your pathway. So what is your pathway currently, and who is the right person or technology for the different parts of that pathway? And it's interesting to me that there's so much focus on AI replacing doctors, or there's another benchmark and AI outperforms a doctor yet again, terrible doctors. I am a physician. I'm an OBGYN resident in the UK. And of course, do you want your doctor to be replaced by AI? And I think the majority of people, if they're getting a cancer diagnosis or having their baby delivered, the answer is no. I mean, I certainly wouldn't, and I work in AI, and I really wouldn't want that person to be something that someone can switch off with a plug, or if there's no internet connection, it no longer works. I want that person to be a human. But there are so many parts of healthcare, as Severance has said, really data-driven parts of healthcare, and thinking about other gaps. And that's what we're doing at Meggie, is actually trying to fill the gaps between your antenatal appointments when you have your baby and you go home and there's very little monitoring, very little education, very little support. So we're thinking about how can we use AI to actually fill in these gaps where and I think there's lots and lots of different areas, but I think about your path. When I think about AI in medicine, it's sort of thinking about your pathway. Who's going to be using it? How will they be using it? How is your whole pathway working? And where can AI add value? So for us, that's supporting women through appointments, through education, where actually that conversational capability is phenomenal, because people are used to getting information that way now. No, people are not going to be reading through academic papers. Very few did anyway. And people are getting used to using ChatGPT, TikTok, short, personalized, informative. So our challenge is making that safe and clinically validated, and making sure we can actually contain these models enough so that they're clinically useful and safe. So that's one perspective. I think there's lots of other things we could talk about, but I'll hand over to Eric.
Well, thank you all. Joseph, you set this up beautifully. I want to circle back on your core topic, and that was the definition of an agent, agentic AI, and wrap that around healthcare, as Severance and Fran described very well. It's a necessity to assure that we have a human in the loop, but in a way that isn't just working with direct access to an LLM. That's simply going to be way too much work, as we've all described here, in ways so that you can take enormous amounts of data, use AI in ways to gather that data, process it, and then present various options for the clinician to operate at top of license. As you've described, Joseph, these LLMs and other AI tools, they are definitely probabilistic. And so that does not lend itself to a decision point that you could make with one option. They can do math these days, but you know what they use? They go out and use a tool. They use the same tool that a human uses. So that brings us back to the definition of an agent. And I think part of it, and you described it well when you described, the framework, if you will, behind this. And with that framework, you can give an agent full autonomy, or it can be assistive. If you give it full autonomy, this is the area we don't want to touch in the world of healthcare, right? That autonomous agent is having a conversation with the patient and could, in all the ways we just described, make a recommendation that absolutely does not make sense. You do not want to put that in front of a patient in its free form of an LLM today, no matter how many ground rules you put behind that. So if you build that framework so that you have structured content that has a clinical governance process with physicians and nurses, everybody that would normally be in the loop, to create that structured content, in a way that in our case, we're gathering information from patients broadly, using some AI tools as well to measure what predictive vitals as well as brain and behavioral risk factors, and then consume all of that data, process it all rapidly, and then following the guidelines of clinical pathways with a clear clinical governance process, present these as recommendations to a clinician to make their own decision, not in an autonomous way whatsoever. It's now assistive in its agentic form, not autonomous. And that's a huge difference here as we're looking through this. So the involvement of a clinical governance process being assistive rather than autonomous, and then putting structure throughout all of that in that harness, as you described it. It's really at the application layer, going well beyond what an LLM can do today.
And I think it's important here to note, Joseph, I'm not sure if you guys saw the studies that came out a couple of days ago where, half of Americans are turning to AI first before they go to initial doctor's appointments. And with the number of hallucinations and the bots getting things wrong, that's a scary, when maybe this technology was actually first developed, right, to predict and create better health. Now the technology may be delaying that vital appointment with that reasoning physician to do that. So to your point, Joseph, there is patient harm that may be happening in an unregulated environment.
And I want to come in on that and bring a sort of women's health perspective, which is to talk about the data that feeds into these models. I think is also really important is that the models are trained on the world as it is. And I think we can all agree that the world as it is suboptimal. And actually, we know that women, and then if you consider intersectionality with ethnicity and race, those individuals are not well represented in medical data sets. And therefore, that bias, that lack of understanding of the fundamentals of a woman's cardiovascular journey compared to a man's cardiovascular journey leads to very real issues in clinical practice. So women are systematically more likely to be misdiagnosed or undiagnosed with heart attacks. They're more likely to receive suboptimal treatment, and therefore they're more likely to die as a result of their cardiovascular disease. And I'm laboring this because this is an American Heart Association webinar. So cardiovascular disease is the number one cause of death of women worldwide, but most women don't know that. Whereas I think most men know cardiovascular disease is, a major contributor to mortality. And so we have to also remember that these models, and actually not just from a large language model perspective, but all data-based models like machine learning, and other data science sort of techniques, they are only as good as their data. And so, for example, there was a recent publication in Nature Medicine which showed that LLMs are more likely to gaslight women with headaches than men. So men are more likely to get the recommendation to go to ED. But because women, I guess, maybe the proportions who have a migraine versus something dangerous, the model has learnt, and therefore it down triages and it gaslights. It's more likely to gaslight a woman than it is a man. And that's very, very concerning. And that's, again, why, as we said, this unregulated, this kind of free-for-all use is really problematic. And there's a lot of kind of under the hood data problems that feed into that, then particularly if you're if you're female, etc. I think the flip side is that actually it really, what Severance has said is like the need and the want, people really want, they are using this, whether we like it or not. This is how people are accessing information about healthcare. So that's something that I actually find very interesting, is that people are seeking a lot of information through LLMs. And so I think we need to try harder to create systems that work, that are conversational, that have these things that obviously are working for people, but can we build them robustly and safely? And I completely agree with you, Eric, that it can never be an LLM on its own. It can't, because they're just too unpredictable. And who knows what the future will hold? Maybe in 5 years, there'll be some breakthroughs. Like, I don't pretend to be enough of a technology specialist, but the way the technology works right now, I completely agree. And I think it's that balance of having enough structure and kind of things which are rules-based, but continuing to deliver what actually consumers want now, and they're getting used to receiving information this way. So it's a really interesting balance, I think.
Just a very, very brief response to that. I think what you're hearing across the board is don't trust the LLM alone. We all have
Mm.
organizations that are building, if you will, that layer on top that brings the safety that's necessary, removes the bias when appropriate, if possible, with data and clinical governance processes so that you can actually use the power of an LLM to bring speed and reduce that laborious work that isn't clinical decision making and present as much information as Severance said as well to make a more effective decision as fast as you possibly can.
And just to pile onto both of those,
Mhm.
right, and to Fran's point, like this is the extension of Google. My mom goes on what is it, WebMD and self-diagnosis. Like this is that on steroids. But the
Yeah.
challenge here is at least WebMD has a base of data to go back to, where the LLM, if it's Google or whatnot, is utilizing what's in the World Wide Web. And to Fran's point is that there is not clinical data on the World Wide Web that is scientifically curated to make those decisions. And so I would propose that the LLM generation is even worse than WebMD. And then the other part of that is like public service announcement. And, we've seen physicians in the US share PHI into these LLMs to get an answer. And number two, there's two issues there. Like, so anybody listening here is never do that, right? That's bad. Very bad. But then also when you put that in there, the large language model is now learning from what you put in there. I have a colleague who's a nephrologist and she's building a model. She built a great model, right? She went back to it the next day and she did it in the right way. And the model was gone, right? Because the LLM, with healthcare, usually there's a safety of 24 hours or something. So,
So there's a couple of things in there I want to touch on briefly. So this will be in my role as a person with an opinion. I want to go back to that idea about a large language model as a transformer or a function that takes an input and makes it into an output. And we've used the word hallucination here, and I just want to clarify that word for this audience because it's a word that gets used a lot. And there's a little bit of sneaking in that goes on with that word. So an LLM transforms X into Y, as we discussed. So whether or not that thing that comes out of the LLM is correct or not, the large language model has no idea what correctness is. So we anthropomorphize these things and we say it was wrong or it was right or it thought about it or it reasoned its way through. It's doing none of those things. It is using a statistical function to create an output given an input. And so to a AI, there is no such thing as a hallucination. There is just text output, and it is us humans, our physicians, our experts, our panels that are overseeing this and governing ones. It's us that says, yes, that is right, or no, that is wrong. So again, Odessa, Paris, or Paris, France, or Paris, Texas, both of those outputs from an LLM perspective are mechanistically the same, and they're both indistinguishable to the AI as correct or incorrect. It is only us, the human, that actually says, yes, that was correct, no, it was not.
Yeah.
And the thing that gets snuck in is we sneak in these words like think or reason or believe or decide as we go on our way. And even hallucination itself is an indication of cognitive state or of cognitive function. It implies cognition of these models. And so even calling these things hallucinations sneaks in these ideas that these machines actually have cognitive abilities that in fact they do not have, which allows for a wave of hype to be unleashed around this. So I just wanted to mark the word hallucination because it's a word that gets thrown around a lot.
Joseph,
Um,
a significant advancement in the technologies have been to go beyond the LLM alone, again, back to agents, where you have a mixture of experts. And those mixture of experts can be that sounding board to say what came out of the LLM, let's validate it. Let's go back to reference sources to further validate that. And that's that layer on top that these applications, the harness as you described it, needs to be in place carefully because we keep talking about the LLM alone and all of its issues. Nobody disagrees with that. How do we put those layers on top, that application layer that can provide a mixture of experts to be that challenger for what comes out of the LLM?
yes. So we collectively, the four of us, plus a whole army of people who are largely like us, have been working for a whole lot of years to bring
I just spoke. I'll hand it to the panelists here, and I'll add to it.
Uh, so I think Joseph, thank you so much for saying, like, giving credit to the fathers who were standing on their shoulders. So I'm a big my idol is Turing from, the late 1940s, right? And machine learning was invented back in 53, 54. Correct me, Joseph, if I'm incorrect. We just didn't have the data pipeline and the ability to store and process the data to get this. So we should look back and say this isn't just happening, right? There was a quote in Bessemer, that's a large financial trust company, and they said, "Why is 2025 and 2026 the year for healthcare AI?" It's because of everything that happened beforehand, right? Like, it just didn't click. All of the patents, all of the hard work, the data, big data infrastructure had to do that. I'll speak from my perspective, right, about innovation, and we're proud of this. Is about 3 years ago, we at DeLorean AI were talking about accuracy, like how accurate is our model, because we're trying to bring this into patient care and area under the curve. We're 89% or whatnot. But now we've moved to real world evidence, and we're really proud of that, right? We're able to decrease hospitalizations in specific areas for dialysis patients, being able to find that fluid overload. But that really has impact on people's lives. And we measure that specific hospitalization by extending people's lives 1 day for every week on the technology. And that's more hugs and kisses for your grandchildren and your loved ones. And then when we look in cardiology, right, being able to predict a cardiovascular event such as a heart attack or a stroke 3 weeks out with a very high accuracy, that increases survivability, especially in rural health in the United States. And I think we should be positive. Like, we've been kind of like the boogeyman. This is LLMs they're flawed, right? We as humans are flawed, but there's a lot of great things that are happening, and it's an exciting time to be part of this and be part of the American Heart Association doing this, right? And I think that technology, now putting that in the hands of cardiologists, right, in the user's hands so that they can help improve it, right? So when we model something and we put it in there and we're looking for our first cardiologist to work with, they tell us that's not what I want to see, or you have the wrong metric, or that wouldn't pop up to me, right? I could have the best technology possible, but if the user doesn't use it, then what was the point of doing it, right? And if it doesn't get the results to it. So I think we're at a really exciting time. I'm enjoying working with, as Fran said, we are on the American Heart Association, working with cardiologists. They're scientists as well and have the ability to give really great input. So I think there's a lot of innovation that is positive for our healthcare systems. I will say one thing: the government has to figure out, and Fran may be different at the NHS, but our government or our healthcare system has to figure out how to pay for it, right? Because physicians, like, I think would adopt even further, but they're not getting reimbursed for the cost of this tech stack that's coming in. So
I disagree with that. I think they are, but I'll wait
maybe you
for.
can help me out, Eric, then. So if you could respond to that point, I'd really love it.
Oh, certainly on the provider side, there's numerous CMS reimbursements that facilitate everything from RPM, CCM, APCM, and more. On the health plan side, we sell to both health plans and providers. In fact, our mission is to get the two to work together for the first time and create a flywheel effect of value add with each other. And they also have the benefit of improving their MLR, reducing their costs when they work together. You've got providers that don't necessarily have the resources to apply this technology and manage a broad population outside the four walls. And I have background in that. I founded the nation's leading remote patient monitoring platform acquired by Optum in 2019 after 10 years of building a system that we were deploying devices, all these FDA cleared devices and logistics and FDA 510K cleared. There was a lot of process and headache associated with that platform. It didn't scale. It reached to 1% of the population. There's other forms of AI, to answer your other question, Joseph, that are the forms of machine learning that we can use this smartphone and its capabilities to listen to your voice for brain behavioral risk, look at your face for measuring predictions on what your blood pressure might be. That technology has been around for nearly 50 years in the form of a pulse ox, now in the last 10 years in the form of what's called RPPG. There's a webinar from American Heart that's already out on that. So we use those technologies using only this smartphone to gather all this information that didn't exist before to know what's going on in advance and be predictive, again, using AI to go, look, what is it you don't know about your population? Well, let's measure them in a way that doesn't require distribution of these complex, expensive devices, even though they are known as clinically accurate, right? And let's get to that 90% of accuracy and acknowledge that this can't be a diagnostic tool, but it's a predictive tool. And then put those predictions together and put all of this information with reference sources behind it, saying, look, here's all that we know that you don't know about this patient outside of those episodic encounters that land inside the EMR and are now on this smartphone in a way that they can make more effective decisions and give them all the tools so it's their decision making that they can accomplish with all of this new data that comes from AI. That's an advancement in how AI can truly now scale from what used to be RPM now to your entire population, because they already have everything they need in that smartphone to be able to measure their health and then give that back to clinicians for effective decision making, assuming there's a clinical governance process through and through involving physicians and nurses in every possible use case.
And yeah, maybe I just wanted to add a little bit more. So about synthesis versus creation. I have a slightly different perspective, which is maybe, but I think it's drawing on those lessons from, broadly speaking, digital health, which is the challenge and the bottleneck is in the implementation. So actually the challenges and the bottlenecks are not usually the technology. And actually there are a lot of challenges with LLMs. But even so, the challenge is getting something to work in an incredibly complex healthcare system, and thinking, particularly for clinicians, things like alert fatigues. Actually, sometimes more data is good, but sometimes more data when you're very time pressured is overwhelming, and you don't want more data. You don't want another tool. You don't want to have to log into another dashboard. So implementation and pathways, I think I keep coming back to, is being I think that the same is true in digital health. Like if it doesn't make people's lives easier, and that's sort of patients and doctors, it's not going to work, even if the technology is absolutely fabulous. So I think we need to remember that. And the other thing is, I think sometimes AI is treated as this kind of special character because it's got this kind of mysticism, right? Oh my God, it's AI, it's intelligence. And I think we've done some great myth busting today. But in my mind, it has to be tested exactly as rigorously as any other device or medication. Can it do harm? Is it safe? What happens when you apply it to a different population? So I think the kind of Silicon Valley mindset of technology and how we evaluate evidence in medicine are two different worlds, and we have to try and find something in the middle where it's this challenge of building fast enough to matter and be relevant and to even be on the playing field, whilst being able to assure and simultaneously often generate your evidence base. And what's really interesting is that often, actually, particularly in women's health, you are having to generate the data as you go as well, because the data doesn't even exist. So it's very hard to move at the speed that you need to, whilst keeping actually the evidence generation up. I do also, but where do I think this is really going to make a difference? I really like what you're saying, Eric, about being able to harness what people already have. And so even in sub-Saharan Africa, smartphone penetration is really high. And so, and I think there's a lens here that perhaps we haven't talked about, which is, what is the status quo? Now, if you're being treated in one of the best centers in the US, I don't think an AI agent, maybe it helps reduce some drug errors, maybe it helps, make the processes more efficient, maybe it can help, build the right data in the right place. But is it really going to change outcomes if you've got access to some of the best clinicians, services, diagnostic services, treatment services in the country? Unlikely. But if you are a woman in Sierra Leone who is pregnant, then actually having access to some information that is highly likely to be accurate. And again, it's interesting, the smartphone parallel, like you're never going to get perfect precision on some of these models, but is it good enough to triage? Is it good enough to screen? And so I think it's very, very context dependent. So where AI may make sense in one setting doesn't necessarily make sense. And again, it comes down to context, pathway, who's using it. And you have to consider what the alternative is. And actually, most pregnant women across the world don't have access to good antenatal care. And so that's, again, a use case where actually, even just the education, this is something that Flow, the first femtech unicorn, they have a great CMO who always talks about primarily what they do is education. 40% of women across the globe don't know what ovulation is. They don't know what ovulation, that word means. And like I'm having to take them at face value. I'm not paid by Flow. But I found that fascinating that actually what they're really doing is helping women to understand their cycles, because a lot of women across the world don't have that education and that knowledge. And so, there's a huge amount that I think when you consider the broader landscape of what people can access, there is the potential for harm, absolutely, but there's also real democratization of education and information. And yes, we have to be very careful, but we also have to consider what the alternatives are. And again, thinking about how we can build these systems responsibly, and bring the benefits. I'm very passionate about actually how can we harness technology to do this scalability, and really rather than yet another wearable, another device, how can we use what individuals already have, because that's actually going to make you be effective in lots of contexts with lots of areas of challenge with access to healthcare. So I think that's a really exciting way that we should be focusing on getting it right, so that we can really democratize access to the medically validated information. Now, the only other note, which is a little bit tangential, is that you can put 5 or 10 doctors in a room and they can give you different opinions. Now, this drives me crazy when I'm a resident, because I ask a different attending consultant over here and I get a different answer. And that's why we have to have MDTs, multidisciplinary team meetings, because different experts have different opinions and they have to come to a unanimous decision for big decisions like what kind of operation are we going to do for cancer? Are we going to give chemo? Should we operate at all? Big decisions, often you have to have this combination of experts. So the idea that there's a ground truth, that there's a right answer, I find really interesting, because medicine, there are guidelines and sometimes it's black and white, but that where it becomes medicine is where you're using your clinical judgment, often in conversation with other experts in your, across different domains. And there's a huge amount of nuance. Also, the patient's perspective, what do they want? And this is fundamentally human. And I think we just need to remember that actually often that there are some areas of medicine where it's a very clear algorithm. I agree, we're likely to remember something, we're human, but a lot of medicine is incredibly complex, and even experts will give you different answers. And that's where I think, again, we need to really think about who are the right entities to be making that decision. And I think often that ends up being a human as opposed to a machine.
I think
If
Fran
I can,
has a really good point. Joe and Eric can comment on this. Fran, I'm not sure you're aware, in the United States, rural health, just like in Africa, is becoming a big issue. And the federal government just passed, is it 50 billion or it's $200 million per state for 5 years to figure out what we're going to do. And I think most states are looking into how does AI, like you described in Africa, like how do we triage, or how do we get the people, or actually recognize people that need to be brought into the primary centers and who can be treated in the tertiary centers. But I'd love to hear, Eric, I mean, have you had experience in rural health, or how
Yeah,
the AI?
absolutely. We're involved with a few different state organizations for the Rural Health Transformation Fund. We are invested in trying to help the communities. In fact, get a message out. We're trying to find ways to even give our product to those that are in desperate need. There are some stark limitations to that, but we definitely want to help where we can, because the technology can now scale for the first time. Um, uh, Joseph, I'd like to cover the topic of some of the standards that are emerging out there for AI safety, governance, and so forth. And I think I want to give credit here to American Heart Association. Percipio has joined this organization specifically in the Center for Health Technology and Innovation, working with Pat and team here to assure that we are backed by science, based in the involvement of the clinicians here, not for technology's sake. It fails every single time. So we have to have these partnerships and relationships that what is it that we can help solve your problems? Where do you not trust? And how can we wrap around it? So there are some organizations. One of those is the AI Care Standard. It's aicarestandard.com that is being formed by groups of providers and technologists to help define what are the rules that we should be applying for how we can safely use AI. And then others like the Mayo Clinic platform, which we're a participant with, they are putting some structure in place to assure that not only is it safe and secure, but it also integrates into the workflows. So we remove that friction of not having yet another screen where their workflow may be primarily Epic or other platforms. So that integration layer is critical as well. So there are different standard bodies out there that are pulling the right threads today, including American Heart, to make sure that we're basing this in science. And that's, I think, a critical part of some of the team members that are here. I don't think we'd be here if that was not our core interest to make sure it's safe and secure.
Yeah, absolutely.
Yeah, I'd love to.
Fran, I just want to
I'd love-
touch back on something you
Go
said
for it.
because it's really near and dear to my heart, which is about the role of that person that we sometimes call the patient in this whole process. And for many years, I've worked in an area known as shared decision making. So here in the United States, up to a third of care is delivered in a context in which there's either no evidence basis for care or which there are multiple evidence-based pathways for care. And the thing that defines which pathway should be pursued is a careful conversation between a clinician and a layperson. And this comes out of Dartmouth Medical School. Jack Wenberg and team spent a lot of time doing the science behind this, and then it's been commercialized through a number of organizations. But this process of shared decision-making, of bringing the person, the patient, back into the loop in a way in which their voice and their preferences and their desires are honored and are instrumental in influencing the pathway is critical. So I love part of what you're talking about is how do we reach this outside of the clinical setting and into these subclinical or non-clinical contexts. And the vast majority of healthcare is delivered by non-clinicians and non-clinical settings, and sometimes we don't recall that, but I love that that's an important part of your focus.
Yeah, and I think that's a great use case. Something that I always feel is we know that, and we call them patients or maybe call them clients actually, because pregnant women in particular, they're not sick, they're just pregnant, and birthing individuals. And we give so much information in 10, 15 minutes, and we know that people will retain less than 50% of that information. So that's like a real loss that, I sit with one of my professors and she gives this incredible spiel, and I'm looking at this woman like, what are you going to remember? And it's even worse peripartum, when you're like in labor and delivery, when you're going home with a newborn, you're absolutely exhausted. And this is the time when we need to monitor your cardiovascular health, we need to improve your blood pressure control. And it's like, you're operating at a time where this is not someone's brain is not going to be receptive to making big decisions. And again, I think there's great value where AI can take what the clinician said. Don't know if that's, clinicians are, I think, are going to hate the idea of someone recording the consultation. But I think this would be amazing. And then the patient can digest it with AI. And this is something that we do in our Meggie on the education side. We have all of the educational content, and they can chat with about what they're learning. So the birth workers that we're training in high-risk pregnancy to really personalize, to understand the information in a way that makes sense for them. So I think that's a really great use case. I also want to just come back very quickly, Stefan, to say we are working in maternity care deserts. So actually, it's a really strong parallel, as you say, and a lot of our work is focused there, and that's where we're taking a kind of community-based approach to upskill the individuals who are already in the community, and then so for example, doulas, community health workers, and they're the ones that we're then are offering the technology to pregnant individuals. So it's a kind of hybrid community and technology approach, because I think that trust relationship is really, really important, and that's a whole other conversation. And then from the regulatory perspective, I wanted to come back on that, if I may, if I've got one more minute, which is from a regulatory perspective, the broader the scope, the harder to regulate, right? So the more that the model can do, the more that the agent can do, then, how do you test that? How do you provide a portfolio of evidence? Actually, what the regulators want, and we recently had an AI and women's health showcase that Meggie held in London. And this was one of the really sort of interesting moments where we had the regulators, the innovators, and the funders in the same conversation is, what they want is for your use case to be narrow. And that's the opposite of what an LLM is, right? An LLM will do anything or try to do anything that you ask it to do. So it's actually very difficult to regulate them just because, the use case, and what you end up is this quagmire where people say the use case is wellness, but actually people are using it for all kinds of different, questions that are very, very medical. So there's a real tension, but I think this comes back to actually being very clear about what your technology is doing, be very clear about your pathway, and then using that to then, that's a much easier regulatory pathway. If you do a bit of everything and you let the models be free and you let your agent make all kinds of decisions, that's a regulatory nightmare. Whereas if you are very intentional and you're very clear on your use case, actually your regulatory journey is going to be earlier easier because you can be very clear on what it is that you do and do not do. And then you can have your evidence to support that. So that's my thought on regulation.
I just want to jump on the regulation thing. I have a couple thoughts. So number one is I am on the other side. Is I don't think I prefer not to regulate as much as possible or bridle as much as possible as the Europeans. I think that is a quick run to the bottom of the barrel with the European Union, and I think it will impact them from a healthcare standpoint as well as an investment and technology standpoint. I'm also cautious that the people who regulate in government don't hear from the right people. So the people that are actually building and doing AI are not the people testifying in front of Congress, right? They have a friend that knows something and who is an ethics person and they're an ethics person. They have a new thing to pontificate about, and they believe me, they can pontificate about anything. So I would encourage regulatory bodies to bring in experts to do that. But what I would also say is that I think the regulatory point of care comes down to the licensed professional, right? Our job, I think, as AI professionals and developing AI is to provide the licensed professional, may that be a physician or nurse or LPN, with the best information and the options in front of them, and that they can make the decision. At the end of the day, it's always, I think, the licensed professional's decision. And I'm not a fan of having an AI make like a literal medical decision without some type of reasoning or human neurons involved. So.
I'm gonna have us pause there. We're right at the brink of the edge of the hour. We did have a question in the Q&A around how do early stage startups find their way? What's the pathway into participating in the shared goal of pursuing better health for populations and for individuals, extending life and extending quality of life? That, as you said earlier, Fran, that's a whole other conversation. But I would offer that the Center for Health Technology and Innovation is a great place to start with that if your technology has relevance to either heart or cerebrovascular or cardiovascular health. This is a very active, very vibrant community, and Patrick Waite, Pat Dunn, and all of the folks at the American Heart Association have done a really fantastic job of creating a community of people who are pulling in the same direction. So for a person who asked about how do you break in, I would offer that the AHA has been working hard to create a place to break in. And then the other thing that I will say is I became aware woefully late that while I may have something to say about AI or some ability to code, I apparently have limited ability to operate Zoom meetings. And so I gave you my slide presentation without actually showing you my slides. I apologize. We will find a way to make that available to you and provide a link some way through the AHA, and we'll be working with that. So again, my apologies. We are now at the very top of the hour. And so I'm going to say thank you, and thank you for joining us. Thank you to the whole team at the American Heart Association. Thank you, Fran, Eric, and Severance, for your time and for your insights into agentic AI.
Thank you.
Thank you, Joseph. Thank you, Eric. Thank you, Fran.
Thank you.